To invite our host for today, Dean David Anderson, who is the Dean of the Faculty of Medicine, who will officially open our session and bring greetings on behalf of the school.
So good morning, everyone. My name is David Anderson, and on behalf of Dalhousie's Faculty of Medicine, I'm very pleased to welcome you to the first ever Canadian Medical Hall of Fame virtual Discovery Days at Dalhousie University, and very excited. This is our 11th annual event in partnership with the Canadian Medical Hall of Fame. Before we begin, I'd like to recognize that Dalhousie University is located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq. We are all treaty people. We also recognize the histories, contributions, and legacies of the African Nova Scotian people who have been here for over 400 years. I would like to also acknowledge that we have with us today the 2020 Canadian Hall of Fame inductee and Professor Emeritus of Medical Education, Medicine, and Pharmacology at Dalhousie, Dr. Jean Gray, with us this morning. Dr. Gray is a testament to the inspiring leaders and role models produced and employed by Dalhousie University, and we're so grateful to have her here with us today.
Good morning to everyone who is involved here. It's too unfortunate that we're not having an opportunity to see one another face to face, but I am going to tell you a little bit about some of the things that led me into where I am today. When I was 13 years old, my family was struck with a whole series of tragedies, and I had a lot of interaction with the medical profession. I had at least one bad role model during that interaction, somebody whose communication skills left a lot to be desired, and a lot of wonderful role models. But the bad medical role model made me decide that medicine was where I wanted to go to see if I could improve the communication between patients, families, and the medical profession. I subsequently, in high school and university, had some really quite remarkable high school teachers and university teachers, and in retrospect, feel very badly that I never thanked them for the role that they played in my career development. Additionally, as I grew older, I began to realize that I was learning a great deal from other healthcare professionals, from patients, from families. And again, I never actually thanked them for this particular role. I was very blessed with some excellent mentors, all of whom were males, so don't feel that it's necessary to have a mentor of the same gender as yourself. One of those mentors was Dr. Anderson's father, and I was always very grateful to him for the role that he played in not only pushing me to do things that I was a little bit scared of doing, but supporting me as I went ahead and did them. But the dilemma that I faced as I got older was a recognition that all of these people had passed through my life, and I don't think I'd ever said thank you. So my message to you today is don't wait till it's too late to thank those who've helped you along the way. And my motto now, very belatedly in life, is have an attitude of gratitude. So I'll turn it back to Heather now and all the staff at Canadian Medical Hall of Fame who do amazing work with very limited resources.
Thanks, Dr. Gray, and thanks, Heather. I'd now like to introduce this morning's Dalhousie Medical Research Foundation keynote lecturer, Dr. Gaynor Watson-Creed. Dr. Watson-Creed is a specialist physician in public health and preventative medicine and is a PEI native. She is currently the Deputy Chief Medical Officer of Health for the province of Nova Scotia and the Assistant Dean for Serving and Engaging Society for the Faculty of Medicine. Dr. Watson-Creed holds and has held several other key population health roles during her career. She sits as a chair or member of several population health councils and boards nationally and is a passionate advocate for high quality and well-organized public health services in Canada. In 2017, she received the William Grigor Award for Achievement in Medicine from Doctors Nova Scotia. And in 2018, she was awarded the President's Award from the Public Health Physicians of Canada for her advocacy regarding public health systems and services in Canada. In 2019, she was named one of the top 100 most powerful women in Canada by the Women's Executive Network in recognition of the leadership she has provided across so many initiatives. She is a dedicated leader and a true ambassador for the role of public health and what it can play in advancing health equity. Please welcome Dr. Gaynor Watson-Creed. Gaynor.
Thank you, Dr. Anderson, and Dr. Gray for your message as well. A lot resonated with me through that. And certainly to the Canadian Medical Hall of Fame and MD Financial and the Dalhousie Medical Research Foundation for inviting me here, and to all of you for being on the line during this crazy time called COVID to hear this, talk this morning. I'm gonna stop for a moment and see if I can share my screen with you. So let's see if we can share this with you. Perfect. I'm assuming that folks can see that. Yes, I'm getting nods. Okay. So what I'm going to share with you today is going to be about certainly, you know, my public health practice, but more than anything else, I'm going to share with you a little bit about the leadership journey that I've been on. And what I would offer you by way of advice as you go on your own leadership journey in science and possibly beyond. And so Dr. Anderson gave a very kind introduction. I do hold a number of hats even here in Nova Scotia. I'm the Deputy Chief Medical Officer for the province. We'll talk about that in a moment. I have a role as an Assistant Dean at the Faculty of Medicine. I'm Chair of the Board of Engage Nova Scotia, which is a large not-for-profit here. And I did receive an award from the Women's Executive Network last year as one of the top 100 most powerful women in Canada. Despite all of that, my kids still call me the diarrhea doc. And you're going to hear a little bit more about why my kids call me the diarrhea doc. And so I'm still to them, you know, sort of best mom and the drive for whenever they need to go somewhere. So I don't have anything to disclose today by way of conflicts, but I will now sort of take you into the role that I have right now. So I said I'm the Deputy Chief Medical Officer of Health. It means I'm a public health physician. And if you haven't met a public health physician before, probably this year you have a sense of who we are and what we do. But I do regularly get some raised eyebrows when I talk about my work in public health with folks really not understanding what that is. It turns out though that there are a lot of us. And as I said, you probably would have seen a number of these folks now on TV that you would recognize. So just to give you a sense of who's in the mix, certainly in the middle of the picture up here.
Excuse me, Dr. Watson-Creed. Oh, I am so sorry. Whoops, we just got your slides. We weren't seeing your slides, and I should have held my breath 2 more moments. I'm so sorry.
So you can see them now. Okay.
We can see them now. I am so sorry, everyone.
Okay, no worries.
Troubleshooting the background there.
The slide that you should be able to see right now has a number of public health physicians on it. So I won't go through them all, but certainly you'll see Dr. Rob Strang, who's the Chief Medical Officer of Health for the province of Nova Scotia. At the top in the middle with the rugby ball, he used to be a rugby player. And next to him on the left, you'll see Dr. Marla Shapiro, who was the health and medical consultant for CTV's Canada AM when that program was still running and on the CTV National News. And so a long career in media, actually, for Dr. Shapiro. We'll talk a moment about why that is. Next to her, Dr. Heather Morrison, who's the Chief Medical Officer of PEI. Below that, of course, Dr. Bonnie Henry, Dr. Dina Henshaw, so the chiefs in BC and Alberta. In the very middle of the screen, though, you see somebody who does something completely different. So this is Dr. Samantha Nutt, and some of you may know her because Dr. Nutt has a history of working with organizations like Much Music and MTV in the US in her NGO called War Child Canada. And so War Child is dedicated to bringing aid to war-affected children around the world. She started that NGO over 20 years ago and continues as a leader in War Child International today. And then, you know, some of my other colleagues from around the country and around the world. So in Canada, there are about 600 of us as medical officers of health or public health physicians. Most of us are in the role of medical officer of health. So what exactly does that mean? Well, this is how I describe it to my parents who seriously, after having supported me to go through all of this education, still really have no idea what it is that I do, which is fine. And so what they describe, or what I describe to them, is that you know, I had the luxury along the way of training as a family doctor as well. And so family medicine is quite a diverse portfolio, and I compare it to public health all the time. And what I say is, if you're a family doctor and you might have then something like 1,500 patients in your roster, so that's the number of patients that you've agreed to be their family doctor. You're not going to see all 1,500 even in a year necessarily, but you'll see 20 or 30 a day for whatever is bothering them. And you have no idea what's going to come in the door at the beginning of that day. So you might go from seeing a newborn baby to giving immunizations to removing somebody's sutures from a recent surgery they had to dealing with a mental health condition to prescribing something for heart failure. And so at the end of the day, you've seen 20 or 30 patients, and hopefully you've done something which with each of those people that makes them feel better. And if you didn't know what to do, you're going to reach out to a specialist community that might have the ideas around what do I do next for this patient to improve their health right now, right? So that's the work of a family doctor. And I loved it. I loved practicing family medicine, and I loved it because of that diversity. When I became a public health specialist, what I realized was that in public health, we also see patients, but as the Deputy Chief Medical Officer of Health for the province of Nova Scotia, as an example, my patient population is now not 1,500 patients. My patient population is nearly 1 million. Now, what that means is that I can't be interested in anything that makes any of those individuals sick at the beginning of a day. But I am interested in anything that makes them sick in groups, or anything that has the potential to make them sick in groups. And I want you to think just for a moment about that potential. That's huge, right? So the things that make them sick in groups could come from anywhere. The drinking water could be contaminated. The air could be contaminated. I always say that one of my nightmare scenarios in the city of Halifax is getting a call from the Navy dockyard or from other port officials to say that there's a noxious cloud of gas floating over the harbor, and it looks like it's going to this community or that community, and what do we do about that? That's a public health issue unfolding in real time, right? Certainly we have all kinds of threats that come from animal populations, and we have all kinds of threats that come from other humans as they pass diseases between one another, like sexually transmitted infections and bloodborne infections. And so as a public health physician, our job is to stand in front of that potential to make people sick in large groups or large clusters. And so our job is fully prevention. And so I want you to think a little bit about what it takes to stand in that prevention place, right? You know, if I thought family medicine was big, I would say that as far as I can tell, there are no limits to what can be considered a public health issue. And quite frankly, if we reach the limits of that, I'm not sure what we're supposed to do, because there are no other specialist communities really to reach out to at that point. Although I think often where public health tends to reach is to government at that point, because government often has the reach to get into these communities and help build the conditions to prevent them from getting sick in large measure. It may not always be 100% successful, but that's the idea. So we're in this big prevention space trying to stand in front of that potential for communities to get sick in large groups and clusters. So here's the thing. If you ever asked me then if I ever had to know anything about the life cycle of a mosquito as a medical student, I would have said, what does that have to do with medicine? Don't be ridiculous. That's entomology. Oh no, wait a minute. That's actually West Nile virus prevention, Zika virus prevention, malaria prevention. Because if you can prevent the mosquito from acquiring the disease in the first place, you prevent the mosquito from passing that disease on to humans, right? So interrupting the life cycle of the mosquito through all kinds of pesticide programs in many parts of the world is actually a robust part of a public health strategy around mosquito-borne diseases, right? If you ever asked me if I ever had to know anything about the engineering of highways as a physician, I would say, why would I have to know about engineering? That's for the engineers to know. Well, it turns out if you can build the highways in such a way that you minimize the impact of the motor vehicle accident when it happens, that's actually prevention. That's preventing the worst outcomes from those motor vehicle accidents. So engineering has a big role to play in preventing those big public health outcomes that we see showing up in our emergency room. If you ever asked me if I had to know anything about how cities are built and have conversations with developers and architects, I would have told you you're being ridiculous now. But it turns out actually that in public health, what I always say to my acute care colleagues is, we can say all kinds of things to patients about what they should do to keep themselves healthy. But the reality is that if it hasn't been built in their community, it doesn't matter what we say because they can't do it. So building communities that support people actually to be able to be outside, to use active transportation instead of motorized transportation, to have green space around them and access to food, that is all public health. That's prevention of chronic diseases and injury. And so I have spent an inordinate amount of time in my career, which I have loved, dealing with city architects and developers and construction officials around how do you actually build a city so that it supports health. That's been some of my favorite work, actually. And if you ever asked me if I had to know anything about the graduation rates of high school students, I would have said, again, that's for the education system to figure out, isn't it? Except that what I now know as a public health physician is that the major determinant of your health is having a grade 12 diploma that means that you are well skilled in math and literacy in your language of choice. Without that, your setup for poor health is actually quite high. And so again, as public health physicians, we spend a lot of time in conversation with school officials and with school populations, figuring out how do we support students not to be healthy in the school, that's part of it, but the bigger goal is how do we support students to succeed at getting that grade 12 diploma that we know is the setup for a good life. So I love public health practice. And I'm terrified by public health practice at times because it is so big, and every day I wake up and if I turn on the news or if I read the newspaper, I know I'm going to see a public health issue that's going to get me thinking during the day. So it's never ending. And yes, we do outbreaks. And so this is why my kids call me diarrhea doc, is because when there is a local outbreak, often the medical officers of health are on TV explaining to the public what's going on and why. And certainly you would see that every day with Dr. Strang, currently being on the news with respect to the coronavirus outbreak. Certainly in my career, I've been the medical officer of health for the Halifax area as well for about 12 years. And we had a lot of diarrhea outbreaks during that time. And my children are younger now, they're 17 and 14, but at the time they were little, and what they said was every time there's diarrhea in a school or in a daycare, mommy's on TV. And so that's what they call me, diarrhea. So we do that kind of work too. So the type of prevention that we do in public health, we call primordial prevention. And so you'll hear health professionals talk about levels of prevention. I won't get into it in any great detail, but the way I describe primordial prevention is that there's a group of professionals, largely family doctors, who are really in the business of making sure that if you have a risk factor for disease, we're going to do everything that we can to prevent it from actually becoming that disease. We're going to work with you to pull back that risk factor so that it's no longer a threat. In public health, we look at whether or not we can actually prevent the risk factor from ever existing. So just think about that for a moment. Prevent the risk factor from ever existing. So again, if you thought about smoking as a risk factor, the way to prevent the risk factor from ever existing is to put controls on people's ability to access cigarettes, to see people smoking, to be influenced by smoking behavior around them. That's why we have all of that legislation around smoking as an example. And there are lots of folks who would say, public health, you chasing the Holy Grail. On the other hand, there are folks who would say, well, we actually do seem to have some evidence that public health has been successful in preventing youth uptake of smoking in particular over several decades. So primordial prevention is that action that you take to prevent a risk factor from even existing. And that's why you have to be at those tables with government and with all kinds of other people who might be able to shape the environment so that those risk factors. I'm going to talk about the training only briefly, just to say it's a 5-year residency program to become a public health physician. And so the way I licensed as a family physician actually was to take my first 2 years and do those exclusively in a family medicine program, which I'm going to say I got away with. Not everybody does that, and certainly the Royal College, which is where my training program sits, is not particularly enamored of that model. So we do it less now, but at the time I had the the ability to license as a family physician and start working as a family physician while I finished my last 3 years of public health training. It was tight, but we managed to get it done. What I love about the training is that we're one of the few groups of doctors that has to have mandatory training in health policy analysis, in program planning and evaluation, and in senior management and administration. And it's because what happens if you train in a public health and preventive medicine program is that folks assume that you're going to end up probably as a medical officer of health somewhere, either for a local town or city, at a provincial level or at a federal level, like Dr. Howard New and Dr. Teresa Tam, our Chief Public Health Officer and Deputy Chief Public Health Officer for the country. Which means that you have to be ready to lead those organizations. And so you can't do that if you're not trained in leadership. And so by the time folks graduate at year 5, we do have an expectation that they've spent at least 6 months in a senior management role, where we basically give them the keys to an organization or a part of an organization and expect them to run everything for that 6 months and evaluate them on it. So that's fun. Again, it's also terrifying, but it's a fun part of the training. The other thing that we get to do is media training, which is a ton of fun, terrifying at first, but then you get used to it. And that's why you see public health physicians in front of cameras all the time. It's because we're fairly used to it. It's a part of our training. And sometimes when we have other trainees with us, for example, our infectious diseases trainees here at Dalhousie University, if they are coming to do any time with public health, we'll offer them that media training as part of their training, just because they wouldn't get it otherwise. And it's good for folks to have. So that's what the training looks like, and that's why in that slide that I had all the medical officers on, you start to get a sense as to how they end up in those different positions. Because really, with that kind of foundation, you can literally go almost anywhere with your career, which is also wonderful. So I'm talking about public health like it's this new exciting thing, and it is. I find it very exciting. It's also not new though. Actually, it has a very, very long history, about a 200-year history of a formal public health system in this part of the world. And so this picture is of Dr. John Snow, not Game of Thrones John Snow, different John Snow, who is considered to be the founder of modern epidemiology, which is the science that public health is based on. And you would have heard a lot this year about epidemiology. And I feel like epidemiology as a career itself has become pretty interesting for folks. So Dr. John Snow is the founder of modern epidemiology, and he was a surgeon actually in London during the cholera outbreak in London in the, I think it was the late 1700s, where he famously discovered that the cholera was being spread through the drinking water system in London. And so that's that primordial prevention, looking at how do we prevent drinking water systems from becoming contaminated. What I love about Dr. Snow's story is that he didn't stop with the contamination of the drinking water system with cholera. He actually identified that the drinking water system in that part of London, the Broad Street area of London, was contaminated because Broad Street was poor. And those residents didn't have the money to pay the taxes to support the ongoing upkeep of the drinking water system, so it fell into disrepair. So he and his colleagues became huge advocates for poverty as a major driver of health, and that remains a central focus of public health work to this day. So you'll hear us talk about things like social determinants of health. Those are those things like poverty, like income levels, like education levels, that we know actually are bigger drivers of somebody's health outcome, whether or not they can truly have a healthy life, even above and beyond what they get from the healthcare system. So that's Dr. Snow. Now, so I've told you a bit about public health practice, but I haven't told you about how I managed to decide that I was going to be a public health physician, and it looks something like this. The slide on the top you will recognize I am from Prince Edward Island, and actually circuitously. So on the bottom left is the town that I was born in, actually. That's Leeds, England, in the UK. I managed to stay there for 6 weeks before my parents up and moved us to Prince Edward Island, where they have been ever since. Now, my parents are actually Jamaican. So I had this long sort of path to public health that I would not necessarily have said was in my brain, certainly, as I went through school. However, I had a mother who was fairly insistent on one thing and only one thing, which is we immigrated to this country so that you too could succeed, my sister and I, who's also a family physician. And succeed only has a few definitions. Some of you who come from immigrant families may recognize this. When I talk to students, they say, oh yeah, my family does the same thing. I call it immigrant family syndrome. So succeed only has a few definitions. One of them is doctor. So my mother told everybody from as long as I can remember when I was little, oh, they're going to be doctors. So I didn't really have a choice. And I don't regret it at all. The other message though that I got from my mother, and my father was a university professor and I watched him do this, was that because we are immigrants in this country and because we are people of color, you are going to have to be prepared to be twice as good as anybody else to get half as far. It's a hard message to hear. And I didn't really understand it when I was little, but I would say I understand it now. And I'm grateful for the message. I did put in that work, you know, sort of to be twice as good, but I'm also sad that, that I had to do that. So there was racism, you know, around, and I'm not going to spend a lot of time talking about this, but you know, I would be remiss to leave it out. Certainly that was there. Some of it was overt, some of it was well-intentioned. Teachers who actually said things out loud, like, well, you know, we think that you would do really well in basketball. You should do that. And me thinking, me on a basketball court would be a complete disaster. I'm, as a grown woman, 5'4". I was never a huge kid. I was never tall. But their reasoning was the Black kids play basketball. And they were fairly overt about that, but they meant well. And so that was some of my experience growing up in PEI, but it wasn't the only experience. I had a tremendous number of teachers that showed me love and kindness, and this was key. So, and I see it today in my own kids. And I heard Dr. Gray talking about, you know, the teachers that she wished she had thanked. I think one of the most important things that I've seen and learned as a public health physician is the value that a good teacher, a teacher who is skilled and knowledgeable, but who also shows kindness to students, those two things are magic in terms of creating outcomes for kids. We actually have evidence of that in the public health literature, the literature around what we call school climate. And so the definition of school climate is basically that kids are coming into an environment of the school where the adults and the kids are able to extend enough love and kindness to the kids that the kids know it's there and they can rely on it and they feel seen and they feel loved when they come into that environment. And I say this to family doctors when I'm teaching family doctors, and they go, can you even evaluate whether or not students are loved in the classroom? Like, is that real science? I say that to pediatrics residents and they go, oh, of course, that's so perfect. Kids need that. And it's true, developmentally, kids need that from adults. And so there's a growing amount of literature that shows that when you have that in a school environment, the kids thrive. And they don't just thrive in terms of their academics, they thrive in terms of their health conditions too. The kids actually get healthier as a result of being in that environment. And I feel like I got that in Prince Edward Island, and so I'm quite grateful for that. And of course, family and friends who believed in me, you know, even when I didn't believe in myself or couldn't believe in myself for whatever reason. And so a big part of that was my sister, Adrienne, who I mentioned before, who's a family doctor here in Halifax. And she's actually the reason that I found public health. And what she said to me was, I was about to enter the residency matching service, which is PARMS, which is where you enter into your specialty program now. And I was really confused. I'd never met a public health physician. I'd never seen public health. And when I got to the match, I called my sister, who was now a year ahead of me in medical school and had just gone through this. And she said to me, what are you doing? Like, you just need to apply to public health anymore. And I was offended. I was offended. And I said, what do you mean public health? Who are those people anyway? Are they even real doctors? How could you say that about me? And then she said, just go look at these websites. Tell me that these programs are not meant to you. And the reason she said it is because she had seen what I had taken on in medical school that interested me. I had done an international elective in a third world country because I wanted to see what those conditions were supporting health in the third world. I had done electives looking at health conditions in the Black communities here in Nova Scotia to see what are those conditions that support health. And a number of things like that. And so she looked at me and she said, it's you just need to do this. And I went to these websites for these public health programs and saw that you could have a career as a physician where you were tackling big, hairy problems and policy questions around how do we prevent people from getting sick in the first place? And I went, oh my God, I had no idea. And so that's how I ended up in public health. So I always thank my sister for putting me on that path, because I would never have found it on my own. So here's what I've learned since then. In the years intervening, which is about 15 years now since I left my residency program, you know, around what it takes in order to stay in this place of being excited about public health. And this is what I would start to offer you by way of reflection as you think about what careers you want to take on in your lives going forward. No matter where I go, I have a little thing that starts to niggle at me if I feel like the integrity of a situation is low. And what I mean by that is when people, what they say they want, what they say they're going to do, and what they actually do are different. Oh, that gets under my skin. So you can imagine, as a Deputy Chief Medical Officer of Health, working largely in government circles, my skin is gotten under a fair amount. But I stick with it for the places where the integrity actually shines through, and I can run with that, and I run with it far when I see it. And so related to that, it seems that I have this yes energy that I didn't realize I had until actually a leadership coach described it to me this way. And so this book, yes, I don't know if any of you have seen this. You may have had it at yourselves as children. I have it on my desk. I bought it for my daughter when she was a toddler, and now I keep it on my desk at the Department of Health and Wellness because it reminds me of who I am. This idea that I like to say yes to people, not just because I don't like to say no, but because if an idea is good, it's worth supporting even if it fails, because we'll learn something from the failure, and then we can have a next idea after that. And so I get really uncomfortable when I'm in no environments, and no can run organizations. I don't know if you see this around you, but no is easy. I call it in Nova Scotia, when I'm talking about this with Engage Nova Scotia, in my hat as the chair of Engage Nova Scotia, I described the Nova Scotia no. It's no, we shouldn't. No, it'll never work. No, we couldn't possibly. No, that's not for us. No, we're nothing like Toronto. We shouldn't even try. And I go, well, why wouldn't we try? What if it does work? Well, I don't see any reason why it couldn't work, and it seems like a good idea. But no can rule the day very easily because folks get scared when they hear no. And so walking through that fear is an important part of what I've learned I need to do in order to stay in those places. And along the way, I have had failure in my career. I'm probably going to have more failures in my career. I might fail again tomorrow in something. But what I've had to learn, and it's been difficult for me to accept this, is that actually the failures don't define me. It's what I do with the next moment that counts. And so that's been really important learning for me along the way. The other thing I've had to learn, and I've really struggled with this one, is to use my voice because it matters. And so as a woman, as a Black woman in science, it's easy to have your voice silenced. But because of all those people around me that I described earlier, who supported me even when I didn't think I had what it took, I learned to use my voice, and now I see the impact of me using my voice, and so now I like using it, and I do it regularly. But I had to learn that. I had to learn to get comfortable using my voice. Now, I've described a little bit about public health. I think I've given you a sense of how big and complex public health can be. And I actually think that big, hairy problems are going to be our new normal, and I'm going to talk more about that in a moment. But the problem is, what I see around me is that not everybody loves complexity, and not everybody can handle it. And I think that's fine if you're an average citizen, but if you're in a leadership position, being able to be comfortable with complexity, I think it's going to be a requirement going forward, because I don't think we're going to get away from complexity ever again. So when I think about what's in front of us and what the year has brought us, coronavirus has certainly taken center stage in many ways. But Black Lives Matter is exposing the big, hairy complexities of racism, which in itself has health outcomes attached to it that we have to pay attention to, and untangling everything that's there. It epitomizes the complexity of the types of situations we're going to see. These weren't the first complex ones. Complex issues have been knocking at our doors for decades now, but accelerating, I would say, over the past, maybe 5 to 10 years. Me Too is exposing complexity that we're going to have to deal with in a leaderful and thoughtful way. Vaccine hesitancy has been named by several organizations internationally as one of the biggest threats to the world's stability going forward. And of course, climate change is going to take us there, whether we want to admit it or not. And nothing is going to be more complex than climate change, I don't think, as a human problem that we're going to have to tackle, and hopefully tackle in a way that helps us sustain ourselves going forward. So if that's what's ahead of us, then your challenge, what I would put to you today, is that as future leaders, you have now a responsibility to take on complexity in the way you think about your leadership. So leadership isn't only about having the brightest ideas, it's going to be about the leaders who can hold a complex space when nobody else is willing to, or when nobody else feels that they have the capacity to. And so a couple of things that I would offer you before I close with respect to that. First of all, I would say, remember that you're going to hear people talk about the system, and the system is doing this, and the system is doing that. Systems are constellations of people and actions and their interactions. And so that means that if you can find the right people to take on the right actions, you can change the whole system in a way that might be beneficial. And you know what? If it fails, it's probably not any worse of a failure than what was going to happen with the system anyway, without intervention. So be thoughtful about it, but don't be afraid. The system is not going to be smarter than you because it's only people, actions, and interactions. Ultimately, that's what it comes down to. So if you spend the time to separate, you know, sort of what seems like background noise from what's really starting to surface at the top as the real issues in the system, and pay attention to those, you have the capacity to make a difference, even in a complex system. Just recognize that if you're effective, the system, the people, and their actions may see you as a threat, because people get very comfortable in systems around staying the same and doing the same thing, because nothing terrible seems to be happening, even if nothing great's happening either. People get attached to the status quo. And so this is a quote from Nancy Pelosi earlier this year, when she noted to her daughter that if you're effective, you'll be seen as a threat. And so my challenge to you is, go ahead, be effective, be threatening, threaten mediocrity and insincerity and lack of results, if you have good reason to believe that the next level is worth fighting for. So be the type of leader who can avoid being trapped by systems that are going to resist change. Say yes to ideas, because failing is not the worst thing that can happen, but failing to try will be the worst thing that can happen. Staying the same is never going to be an option. Call out, I was going to use a different set of words here, but I've chosen obfuscation, misdirection, misdiagnosis when you see it. So that idea that when something looks bad and nobody around you is saying it looks bad, you get to call that out and say, no, actually, it's actually bad. And chances are you're not the only person calling it out. Other people are seeing the same thing. So feel free to speak truth to power. Practice that. You can do it respectfully, but do it. Don't stay silent, because your voices need to be heard. And sometimes that means that you're going to sacrifice relationships because the issue is that important. Not every issue is going to be that important. And I've had to learn that in my career. And not all issues are going to be that important, because you'll drive yourself crazy. You'll exhaust yourself chasing them all. But there will be a few where you'll look at them and say, this is so low integrity, so potentially detrimental to so many people, I can't stay silent. So don't stay silent, and find the people who will support you to use your voice. Ally with other people whose voice needs to be heard, but they don't feel that they can speak it, and speak for them or with them if need be. Listen hard, as much for what is being said as for what's not being said in a conversation, because often in complex systems, leaders are valued by how much they say. And in fact, speaking more, being the tallest, being the best dressed, doesn't necessarily define you as the best leader in the room. And so be aware of that, and listen for the other voices in the room who might not be taking up all the airspace. Similar to that, you know, something I had to learn early in my career was that there's value in listening just to listen. Often when we're listening to a conversation, we're thinking about, what is my response going to be? And actually, you could put a pause on waiting for your turn to respond, and just be in the act and the moment of listening, and see what that brings you before you respond. And finally on this slide, what I would say is don't let systems take away your time for thinking. Systems are good at keeping people busy, and the busier you are, the harder it is for you to use your big brains to apply to the problems that actually need looking at. And so don't mistake busyness for effectiveness. Take the time to do the thinking that you need. Your brains are what we will need more than anything else. Your busyness is secondary to that. Bring us your good thoughts and make the time for those thoughts to happen. Finally, I think I would offer you that if you are going out into the world, you know, in this leadership quest, and I'm not suggesting that you all have to be leaders, but if you find yourself in that place, be prepared to see the world not the way you want it to look, but the way it actually looks, because we need more people to see the world for the way it actually is, so that we can deal with how it actually is instead of being surprised by that when it pops up. And I think too often I see around me leaders who actually are looking at the world but only seeing what they want to see. And it's such a complex place now. We actually need to see it for what it is. So I challenge you to do that, knowing that it's so tempting to see a rosy picture. And I hesitated about putting this slide in because I don't want to leave you sort of with this impression that it's all doom and gloom. But I think it's too easy to see a rosy picture when actually the picture is more complex than that. And so be aware of that and be prepared to see the complexity and even some of the ugliness of that as needed. Having said all of that, I would say the world and its people do have beauty and brightness and depth. And so that's what will sustain you. And that's what we will need you to pay attention to supporting going forward. So find it and then just do good things. At the end of the day, that's what I think this journey is about. And you know what? Life doesn't just work out. This means, you know, putting some structures in place and setting goals and seeing where you can get. But at the end of the day, whatever happens, you'll find your way to a new beginning. So the end of something doesn't necessarily mean that you failed. It doesn't mean that you can't go on from there. You know, if it doesn't work out the way you think it will work out, whatever happens next is still a bright possibility waiting for you to explore it. I think that's all I wanted to say today. I hope this is what you thought you might get from me today. Thank you for your attention. I have no doubt that a group like this can do fantastic things for the world. And so we're waiting for you in your next roles and next careers, and whatever your life brings. I'm certain that you have what it takes to handle it.
Thank you, Dr. Watson-Creed. I am so glad that you said yes to my colleague Nani when she invited you to do our presentation. We now know so much more about the vital role, the importance of public health, and also the importance of showing love and kindness. There were just so many powerful messages in that presentation. So thank you so much. Again, thank you to Dr. Jean Gray for joining us this morning and your important message of expressing gratitude. It's lovely to see you again and to hear from you as well.